Hi, I'm Dr. Dana Rice. I've been practicing here in San Antonio since the year 2000. I do general surgery and weight loss surgery and have been since that time. I know you're going to want to, but please don't multitask during the seminar. It's really important. And when you come for your first appointment, there's a test. And if you miss too many questions on it, you may have to watch this all over again. This is part one of the seminar. It includes procedures I offer in my practice. Body mass index is a way that we can compare patients of different body styles, say apples and pears. And it's basically your weight over your height. And a BMI of 20 to 25 is considered ideal. Once you get over a BMI of 30, the risk of having surgery to reduce your weight is less than the risk of staying that weight. Put another way, once you get to a weight that qualifies you for surgery, the risk of dying or having other medical complications as a result of that weight is higher than the risk of having surgery to reduce it. Some of the various weight-related medical problems include sleep apnea, diabetes, high blood pressure, joint pains, back pains, reflux disease, and a whole host of other things. Sleep apnea is number one on that list for a reason, and that's because about 85 to 90% of patients who qualify for surgery also have sleep apnea. And sleep apnea can be a killer around the time of surgery. So it's very important that if you have any of the symptoms, we want to send you to get a test to see whether you have it or not. If you do have it, you're going to want to get it treated around the time of surgery and for the first month or so at least after surgery. There are other consequences of obesity as well. Fatigue, decreased opportunities at work, not being able to keep up with the grandkids, problems with airline seats or movie theater seats. All of these things get more difficult as your weight goes up. Most patients will have tried a variety of other ways to lose weight. Those studies show that only about 2% of patients will find a diet that will work for them. By work for them, I mean not only get the weight off to begin with, but to keep it off over the long term. Now 2% is pretty measly, but dieting is a lot less risky than surgery, so if there's a diet out there that you believe you can use to help yourself lose weight and to keep it off, you owe it to yourself to give it a try. Because again, dieting is less risky than surgery, and surgery should be considered the last resort. The main procedures I offer within my practice are the laparoscopic gastric bypass surgery, as well as the laparoscopic vertical sleeve gastrectomy. Some patients are interested in the lap band or laparoscopic banding procedure. However, I am currently not performing very many of these. If it is something that you're interested in, when you come for your first appointment, we can discuss it fully. With the gastric bypass procedure, we divide the stomach and create a tiny stomach pouch about the size of your thumb, and then we divide the intestine and hook it into that stomach pouch. The pouch naturally enlarges over the first couple of years. Absorption of medications and such is all completely normal. With a gastric bypass surgery, there are several mechanisms for weight loss. The first is that the tiny stomach pouch limits the amount of food you can take in at one time. The second is that that piece of intestine that's hooked into the stomach pouch does not react well to sugar. Sugar would normally be digested by the time it would get down there. So when you eat or drink something high in sugar, like say M&Ms or a regular soda, that piece of intestine freaks out and thinks, oh my gosh, how did this much sugar make it down that far? So it goes into panic mode and throws a whole bunch of fluid into the intestine to help with dilution, and that gives you some symptoms. If you've ever had a low sugar attack where your heart's racing and you feel like you're going to pass out, it's that kind of feeling, and that's called dumping syndrome. And that's the second mechanism of weight loss that goes along with gastric bypass surgery. And the third mechanism of weight loss is that hormones are rebalanced when you have a gastric bypass, so that there's decreased hunger, which allows you to not only take the weight off, but keep it off over the long term. With the vertical sleeve gastrectomy, about 85 to 90% of the stomach is removed. So that has a direct impact on both your hunger, because some hormones that create hunger are created in that part of the stomach that is removed. Also, the smaller stomach decreases the amount of food that you can take in at one time. The sleeve gastrectomy was first performed in about 2005, so it is a newer procedure, and the long-term risks are not known at this time. You might be thinking, which procedure is right for me? Well, both procedures are done laparoscopically. The gastric bypass takes about an hour to an hour and a half, whereas the sleeve is usually less than an hour. You're usually in the hospital for 1 to 3 nights for each procedure. Back to work at about 1 to 3 weeks for each procedure. If you remember, I talked earlier about dumping syndrome, and that is associated with gastric bypass. It is very effective with helping keeping you away from foods that you shouldn't be eating anyway, things that are high in calories and low in nutritional value, and things that are going to sabotage you and your weight loss as you go along. The gastric bypass has dumping syndrome associated with it. The sleeve does not. There's a special relationship between gastric bypass and both diabetes and reflux. If you have significant diabetes, you might want to consider that a gastric bypass is your best option. The same goes for reflux disease or heartburn. With the gastric bypass, most patients will come into the hospital and by the time they leave at 2 to 3 days will not require any of their diabetic medication anymore. This is fantastic, and if you have significant diabetes, you might want to consider that a gastric bypass is your better option. The mechanisms for this are not completely understood. However, we do know that in diabetic mice, that if you disconnect the first part of the intestine from the stomach, that the diabetes goes away. And when you hook it back together, the diabetes comes back. So this is what happens when you have gastric bypass, and it's been documented for over 40 years, as long as the gastric bypass has been around. With the sleeve gastrectomy, you have to lose whatever weight is necessary to have your diabetes be impacted. With reflux disease, the gastric bypass is actually a treatment for reflux disease. So if you have reflux that's significant that requires surgery and you're over a BMI of 35, the gastric bypass would be the actual surgical treatment for you. If you have significant reflux and you have a sleeve gastrectomy, you can make your reflux significantly worse. So it is not recommended in patients who have significant reflux preoperatively. The average BMI decrease with the gastric bypass is about 17 points, or about 62% of your excess weight. With the sleeve gastrectomy, it's about 15 points, or about 57%. So the weight loss is a little bit less on average with the sleeve and a little bit more with the gastric bypass. Also, the weight loss continues over a longer period of time with the gastric bypass in our experience. The long-term data with gastric bypass surgery is that 85% of patients will lose at least half of their excess weight and keep that off over the long term. And by long term at this point, we mean over 40 years. That's pretty good. That's a lot better than that 2% chance that you'll find a diet that'll help you get the weight off and keep it off. The diet after surgery is very important. We basically don't want you to eat until you're actually hungry. We don't want you to eat more than 3 times a day. Does that mean you have to eat 3 meals a day? No. It means if you get to a 3rd meal in a day, you're done for the day. We want you to spread your meals over 20 to 30 minutes. We know that that's the right amount of time to give you the amount of food that you need without eating too quickly. We want you to minimize the amount of starches and sweets that you eat, because those are things, again, that'll sabotage you in your weight loss, especially over the long term. We want you to drink all the time to keep yourself hydrated. We also want you to separate your eating and drinking. Once you start eating, we don't want you to drink at the same time, and we want you to wait for an hour after you eat before you start drinking again. The reason is that right after surgery, everything's a little bit swollen and tight, so if you put food into the stomach pouch and then pour water on top of it, it's gonna not go anywhere, it's gonna not wash down, it's gonna end up coming back up. So that's not good. And later on, as you get less swollen and things open up, you put food into the pouch. If you drink water on top of it, it's gonna wash food down and you're gonna be hungry again faster. So that's why we want you to separate your eating and drinking. As far as physical activity goes after surgery, you can't do too much. We get you up walking the day of surgery while you're in the hospital, and that's not to torture you, that's to help keep you from getting blood clots and pneumonias. And then we want you working into an exercise program as quickly as possible. We'll release you to do whatever activity you want, generally at your 2-week appointment. Weight loss surgery does require a mental commitment going into surgery. Get ready to change your eating habits. Get ready to increase your activity. Get ready to deal with any issues you may have with food. And when you come for your first appointment, we'll have you see a therapist to find out what your triggers are with food. Get ready to change out your various medications for vitamins and minerals that you need to take over your lifetime to help keep you healthy. The vitamins and supplements that we want you to take include multivitamins, B vitamins, vitamin D, iron, etc. And we'll talk with you more about that when you come for your first appointment. And get ready to come back and see us over your lifetime, because study after study has shown that patients who come back for their follow-ups and let us help you keep on track are going to, in general, do better than patients who don't. This concludes part 1 of the seminar. To continue the seminar, click on part 2.